Dr. Lederman's custom prostate cancer treatment is all outpatient. Our goals are your best results, avoiding radical surgery, maintaining your sexual and urinary function, and your life. Most insurances, Medicare, Medicaid, accept it. Call Dr. Lederman at 212-CHOICES, 212-CHOICES for a fresh second opinion and free booklet DVD. Not only super convenient, super. In Manhattan at 38th and Broadway. Custom tailored treatment to hit the cancer. Call Dr. Lederman, 212-CHOICES. Cherish your life. Custom prostate cancer treatment with Dr. Lederman. 212-CHOICES.
Welcome back to the Radiosurgery Hour. This is Rob Redstone here with Dr. Gil Lederman at the WOR Studios in the heart of New York City. We're just a few steps from the Radiosurgery New York Cancer Treatment Center on Broadway and 38th Street. Dr. Lederman, the leading cancer expert, treats prostate cancer non-invasively. He was the first in New York with fractionated brain radiosurgery, and he's the first in America and in the Western Hemisphere with body radiosurgery. You can also call Dr. Lederman at 212-CHOICES for a free informative booklet and DVD. Hey, Dr. Lederman, we're back.
Hey, we're back, and I hope you're all doing well. This is Dr. Lederman, Radiosurgery Hour, talking about cancer treatment, how to live a better life, and we're talking about many, many things. Ariel Lederman just notified me that he's updating our data when he heard that Whipple procedure has an average survival of 15 months. To go through that big operation, cut out your pancreas and your duodenum and sometimes your spleen and other organs, and then the average survival for pancreas cancer after that big operation is only 15 months. Wow. That's why we like to do non-invasive work for pancreas and other cancers. Our success rate where we aim to beam for pancreas cancers is it's about 94%. So it's a highly effective treatment without the cutting, without the bleeding, without the hospital stay. And that's true for cancers in the pancreas as well as in the liver or adjacent lymph nodes or sometimes even elsewhere. An interesting woman who came in, to change the topic, 50-year-old woman from Brazil. And you probably think of people from Brazil. We shouldn't generalize, of course, but this woman is blonde. I mean, her skin was so fair. She looked like Snow White with blue eyes. So you can imagine she's someone who's very, very susceptible to sun exposure. Well, her father, who also had this very fair skin, had skin cancers. She saw a surgeon a year ago and had surgery January for a basal cell cancer of the left lower eyelid towards the nose area. That's what's called the medial portion by the tear duct. So they did what's called Mohs, M-O-H-S, Mohs surgery on her. Mohs surgery is where they're supposed to be slice. They slice the cancer until they don't see any cancer anymore. So it was developed for very difficult cancers. And now, unfortunately, probably for financial reasons, it's being commonly done for almost all skin cancers. And there's a big article, and I refer you to that in the New York Times about 6 months ago about the financial issues. This woman has no insurance. She came from Brazil. She's a missionary. So she had Mohs surgery 6 months ago for this cancer, basal cell of the eyelid. She is deformed. She had problems with the tear duct. She has problems with the eyelid, which is not the worst of it. The worst is, she has all that deformity. She has a problem with the tear duct. She has a problem with the deformity of the eyelid. And now, 6 months after Mohs surgery, the cancer is back. And it's back over at least a half an inch, 3/4 of an inch of her eyelid. And she's coming to us. Actually, one of our patients, a man who I treated for prostate cancer, who was a great listener, he's probably listening this morning, brought her to us because he knew that surgery ain't so hot. And in her case, it didn't even last 6 months. Mohs surgery for basal cell cancer. Obviously, we treat a lot of skin cancers, and I talk about it because we treat so many. I had very close friends and acquaintances in dermatology for 30, 35 years. I wrote many papers about dermatology and had close relationships. And so we, for that reason and for other reasons, have seen many people with skin cancers, basal cells, squamous cells, Merkel cells, melanomas, treating with radiation. Well, we offered her treatment, and she wants to go ahead with radiation because she's had the Mohs surgery, which did not work. The cancer came back within 6 months, and it left her deformed. So I saw her, I examined her, I told her to go home and think about it. We like everyone to think. And she's notified me she wants to go ahead with treatment. By the way, we had a man who flew up from Texas with a Merkel cell cancer. So Merkel cell is a particularly aggressive cancer. He was treated in Texas with surgery and radiation and chemo, and none of it worked. Actually, the cancer kept on spreading. It looked like wherever the surgeon touched, the cancer kept spreading. There was little nodules like marbles down the right side of his face from his eye to his chin, multiple nodules, boom, 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 boom. He was told in Texas, and he went to big hospitals there, that no one could help him. Came to us. We've treated him. He is now in remission. So it's fantastic for him, fantastic because I'm happy that he's happy, and I'm happy that he's in good health, and I'm happy that he's now home. He went home to Texas yesterday in good shape, in cancer remission, with no side effects. Another patient who came in, she came in, a 44-year-old woman, married with one daughter. She came in with a history of breast cancer. So she had a right breast cancer treated in the past with chemotherapy and surgery. In 2013, last year, she had a recurrence of her cancer with high markers. There's cancer markers, and any one of you with cancer should know if there's markers or not, because markers may tell you if the treatment's working or not working. Well, her CA 15-3, 27-29 came back at 700, and she had cancer in the lung, the liver, the bone. And for the last several weeks, she's had severe headaches and dizziness, and nothing was done until 2 days ago. So when a cancer patient in particular has headaches and dizziness, worst of her life, she said, and loss of balance, if it were me, I'd do a scan immediately. Doesn't pay to wait 2 weeks. Just means cancer's growing in her. Actually, she ended up in the hospital. She had a CT scan. She should have had, I think, an MRI. An MRI is more accurate. But she had multiple brain metastases, and the brain is locked in the skull. So the skull is not going to move. And what happens when you have cancer in the brain is it pushes on the brain and it hurts the brain. And actually, in her case, it starts pushing the brain down the little tube called the spinal cord area. So, in fact, her brain was herniating through the little hole where the brain leads to the spinal cord. She was in big trouble. We saw her. We started her treatment emergently. We gave her medications. And even within the first day, she said she was better. Her husband said she was better. So she's under treatment. We were pell-mell, not waiting a moment to deliver her treatment and her medication for brain metastasis. Brain metastases, by the way, are very common in cancer patients. About 250,000 cancer patients have brain metastasis. That's when the cancer gets in the bloodstream, spreads to the brain. So if you're having headaches or new symptoms, you should give us a call. Come in immediately. It's an emergency. You don't want to have damage to the brain from cancer that can be prevented. Give us a call. You can call day or night, 212-CHOICES, 212-CHOICES, which is 212-246-4237. We want to find it before it hurts you. And there were some articles in the literature this week about screening for cancer, and it's interesting that screening for lung cancer is a very hot political football. There was an article written that by Edward Salem. He was a medical writer for Health Republic Insurance, and he wrote in the New York Times this week that as for winning the battle, he's talking about cancer and lung cancer and smoking, reducing the lung cancer deaths by 20% may be significant, but we already know how to reduce the number of lung cancer deaths by 90%. Regulate cigarettes out of existence. Well, he wants, I guess, the government to regulate cigarettes. Maybe it would just be better if we stopped smoking. Stop spending $15 for packs. Stop getting all those toxic chemicals in our body that can cause throat cancers and esophageal cancers, lung cancers, kidney cancers, bladder cancers, leukemias, lymphomas, heart disease, and give us bad breath. Your lovers are going to get a fresh breath without all that smoke coming out of your mouth. So there's lots of reasons to stop smoking. We don't need a government to regulate. We can just use common sense. Let's stop smoking. Let's get healthy. And there's another article by John Williams, who's an internist at Duke University, and he wrote to the New York Times, here's some additional facts and issues to consider from the Veterans Affairs publication called Screening for Lung Cancer. Number one, the evidence for benefit is based on a single, carefully conducted study. It's unclear if the benefits shown in the study will be replicated in routine practice. Number two, the benefit of screening is small but important. According to research with screening, 3 fewer people out of 1,000 would die from lung cancer over 6 years compared to those electing not to be screened. The potential harm of 1,000 people screened over 3 years, 365 will have a false alarm. False alarm leads to additional testing, and some patients may have complications from this testing. Point number 4, only 25% of the participants in this study were older than 65, and none were older than 74. False positive rates and complications from biopsies of lung nodules are higher in older adults. The potential benefit from lung cancer screening in older adults may be less than observed in the trial. He writes that while it's laudable that some hospitals provide CT screening free for all, patients will need good insurance for further testing and treatment if they have a positive test. I'm not arguing for or against screening, but rather that people should have the facts and discuss them with their physician about what's best for them. The facts, that's exactly what we like here, the facts, the facts. And here's one last article or letter written about that by David Craig, and he says, as a supporter of Obamacare, I find the article hopeful and worrisome. They report improved lung cancer survival for current and former heavy smokers who have a CT that costs several $100s. They add that screenings will be more affordable when the Affordable Care Act lists them as free preventable services in January 2015. They urge Medicare to follow suit. But, interesting point, what's free? Well, what's free? Okay, so here he writes in New York Times, individual affordability means shared expense. So it's not free. The writers note the estimated 9 million beneficiaries, but not the collective cost of perhaps $3 billion or more based on their figures. As the Affordable Care Act increases our shared responsibilities for one another health care, perhaps we should limit free, quote-unquote free. That is, what's free? He says, that's right, it's jointly paid. We should limit free preventable services to cases involving a common health threat rather than a personal risk. So he's saying, just because you smoke, why should everyone else pay for your smoking and your screening? Why don't we all pay for things that are collective, like tuberculosis exposure or polio, but not for something that each person does? So there are 3 different views on lung cancer screening in heavy smokers. If you are a heavy smoker, you may want to get screened, or better yet, come in, talk to us. We're at 212 Choices, and we're happy to sit down, spend time with you, and tell you what the options are. If you're a smoker and you want to know, can you be screened? Can you find out what's going on? Do you deserve that? Do you want that? Do you know what it means? So give us a call. My name is Dr. Lederman at Radiosurgery New York. We're a private cancer treatment center, and that's all we do. We take care of patients. We have no kickbacks from the drug companies, from pharmaceuticals, from surgeons. No, we're a private center taking care of each patient one